Hello, I have decided to do the presentation so that I could be more focused. I'll start by thanking everyone for coming on my presentation for CLABSI. I know a lot of us will just be getting off of work, and so I hope my presentation will be entertaining. The purpose of this presentation is to raise awareness among professionals about the issue of CLABSI and the CDC bundle for preventing CLABSI. Thousands of people die yearly because of CLABSI. Some studies state up to 35%. The PICO question for this presentation is, in a critical care population, are CLABSIs far more prevalent and can be decreased using CLABSI bundles that can lower the CLABSI rate to 0 during the patient hospitalization? This is a brief literature review, of course, using peer-reviewed journals in English, and I'll spare reading it to you. I've broken down the central line bundle into 5 basic points: proper hygiene, the full 20-second in between the fingers, on top, under the cuticles, etc., and the bathing of patients with chlorhexidine wipes that we use every day. Using sterile technique during insertion. I know at our facility we do not insert ourselves, however we do help the practitioner, and it is of the utmost importance that we assist the practitioner with maintaining a sterile field, such as handing tools with sterile techniques, staying in the room to assist with any issues that may arise so that the practitioner can maintain their sterile field. And as we know, that can vary from running to get something unexpected to crawling under the sterile drape and holding a patient in position. Sterile technique during the dressing changes, we'll go into depth in this presentation and give a reverse demonstration after. And proper port access, which can be a little pressing. We have some very critical issues that require emergent action. A swab to the port for 20 seconds during a code is not always advisable, but it's turning into a must. Timely equipment changes, such as our favorite IV tubing dating, making sure that everything is dated properly, such as propofol every 12 hours, our TPN, etc. This slide covers proper hygiene. Hand washing is a must before changing dressings and before port access, even when gloves are being used. And the patients need to be bathed with the chlorhexidine wipes that we have access to. This is really every inch of the patient, but for the mucous membranes, that includes a hair, feet, eyes, or eyelids, except for the inner ear and in the nose, or occlusive dressings. They can be used on transparent dressings. This slide covers proper hygiene. Hand washing is a must before every dressing change and before port access, even when gloves are being used. And patients need to be bathed with chlorhexidine wipes that we have, and that really must be every inch of the patient except for the mucous membranes and occlusive dressings. Wounds, transparent dressings, hair, every inch of the patient really needs to have contact with the chlorhexidine wipes. If possible, lines impregnated with rifampin and minocycline should be used. I know that's something that management is looking into for us, but we don't have them available to us just yet. As mentioned, passing the sterile equipment properly. We should encourage intensivists to avoid the femoral area if possible. We're often limited in an emergent situation as they're wanting to avoid the thoracic area to avoid lung collapse. But if the patient is obese, it's just a dressing nightmare and should be avoided. The biopatch should be applied to sites that aren't bleeding. The edges must touch or they're not much good. The dressing should not be compromised in any way, no bunching, wrinkling, moisture. We often wrap the site with sites that bleed with Surgicel and apply sterile gauze, but these dressings must be changed every shift and as they become soiled, and they should be changed as soon as possible to transparent dressings. Dressings should be changed every 7 days and, of course, when needed, dated using sterile technique, masks applied to both the nurse and the patient, and changing the dressing area should be cleansed with chlorhexidine and allowed to dry, no fanning, just letting it dry, and approximated biopatches. So, proper technique: wash hands, apply clean gloves, remove the soiled dressing and take off gloves, apply your mask and the mask to the patient if necessary, wash hands again, apply sterile gloves, cleanse the site in a clockwise motion, starting at the insertion site and moving in an outward motion, being sure to cleanse every bit of tissue that's going to be underneath the dressing. Allow to air dry completely, apply the biopatch so that the edges are approximated, and apply a dress or a date and make sure it is legible. Gauze dressings are similar. Sterile technique is still used. Everything is the same. However, instead of the biopatch, Surgicel can be applied to the area if there's excessive bleeding, and then sterile gauze is applied. Of course, the timing and dating is very important because it needs to be changed every shift and whenever it gets soiled. Transparent dressings must be changed if biopatches appear swollen or bloody. Ports need to be scrubbed with alcohol for 20 seconds before every single access. So count that out: 1 1,000, 2 1,000, 3 1,000, 4 1,000, etc. and so forth. It seems like a long time. That needs to happen between every single access. Sterile equipment should be the only thing used to access these ports. If you found an open syringe in the drawer, don't use it. If you touch the end of the spike that is going into an IV bag, discard the tubing and start over. Strict sterile technique needs to be applied with, port access. Ports are also supposed to be changed with every dressing change, so at least weekly. Port covers that are impregnated with chlorhexidine are highly recommended, but of course we don't yet have them on our unit. All tubing should be changed per policy. Our policy is every 4 days. Certain drips, as I mentioned, require more frequent, propofol, TPN, etc., and I think we all know those criteria. Sterility is of the utmost importance. Any compromise of the sterile field needs to be addressed. Outdated tubing, compromised dressings, anything that can put the patient in danger of CLABSI. This ends my PowerPoint presentation. Will now be going into the demonstration, and then you'll be demonstrating back to me. And again, thank you for listening to me.